cardiologist and one of our teachers in the course. And he is going to teach us about diagnostic test evaluation and various tools which are used for testing the diagnostic tests. Dr. Sourabh, please start the presentation. Please start your talk. And we'll keep the questions reserved till the end so that they can be taken up by Dr. Sourabh and others. Dr. Sourabh, please.
Thank you, Professor Meenu Singh. It's a pleasure to be talking about diagnostic tests. Thank you very much for inviting me to take this talk. Diagnostic tests are extremely important because we use diagnostic tests every day of our lives in our clinical work. We may not take that many therapeutic decisions on a day-to-day basis, but diagnostic decisions are taken almost every day when you go for rounds. So even when you take an item on history or you do a physical examination, that physical examination sign itself has a sensitivity, specificity, positive and negative predictive value. So, every day of our clinical lives, effectively, we are using the principles of diagnostic testing. Before we go any further, I'd like to clarify a few terminologies. First is, what is a gold standard? So gold standard is an investigation that for all practical purposes defines that disease. That means if the gold standard is positive, the patient is diseased. If the gold standard is negative, there is no disease. And often, though not invariably, gold standard tests happen to be expensive, invasive, potentially harmful, not easily available, and time consuming. And they're often microbiological, pathological, invasive radiological tests, genetic tests, or they could be the final outcome of the disease. So for instance, there could be researchers who might take the overall course of the illness as the gold standard for sepsis, or it could be a set of criteria. So in pediatrics, the modified Jones criteria, for instance, is a typical example of the gold standard for the diagnosis of rheumatic fever, because there is no other laboratory test or pathological test that tells you that the patient is having rheumatic fever. Microbiological tests are usually, cultures or PCR. Pathological tests are usually, biopsy, histopathology, and so on. So the correct term for gold standard is actually reference standard. And the reason for that is the word gold somehow gives the impression that this is permanent, which will never change, but that's not true. Even gold standard tests change over time. They are not permanent, and they change depending on better understanding of the disease process. So for instance, a culture may be today's gold standard for a particular disease, but it may get replaced by PCR, a few years down the line. What is a diagnostic test? A diagnostic test, as opposed to a gold standard test, is an investigation that is commonly used for taking decisions as a proxy for the gold standard. So a diagnostic test is often cheap, non-invasive, relatively harmless, easily available, and quick. And often it is a simple blood or body fluid test, or a simple X-ray, or even an item in history or examination. Those are all essentially diagnostic tests. So a diagnostic test is always evaluated, its performance is always evaluated against a gold standard test. And the correct test is an index test rather than diagnostic test, because again, that word diagnostic sometimes gives the impression that the diagnosis has been confirmed by just doing a diagnostic test, whereas it is actually a gold standard test that confirms the diagnosis. Now you must get this graph into your heads because it's going to come again and again in this talk. And it's very important to build this concept right in the beginning. So when a patient comes to us for the first time with a set of complaints and items on examination, maybe a few preliminary lab tests which somebody else may have done, you mentally slot the patient on a scale of probability, ranging from 0 to 100% chance of having the disease. Usually, the first time the patient comes to us, the probability of the disease is somewhere in the middle, in a zone of uncertainty. To the extreme left is 0% chance of the disease, which effectively means gold standard negative for sure. On the right hand side is 100% chance of the disease, which is gold standard positive for sure. Now, somewhere close to 100% chance of the disease on the right side is a zone of treatment, which basically means that beyond a certain probability of the disease, most clinicians would treat for the disease without waiting for 100% confirmation. A typical example is sepsis. So, maybe at about 30, 40, 50% chance probability of it being sepsis, most clinicians would start giving antibiotics because they are already in the sole zone of treatment. They would not wait until they have 100% confirmation of sepsis through a blood culture or some other definitive test. Similarly, on the other side, on the left side, you have a zone of discharge. That means if the probability of the disease is so low that for all practical purposes you can exclude it, then you don't really wait for reaching a 0% chance of disease. You just say that, well, I'm discharging this patient from any further investigations. Now, where are these thresholds put? That entirely depends on the type of the disease. And there's no magic formula or magic number for deciding these thresholds between uncertainty and treatment on the one hand and uncertainty and discharge on the other hand. So there is a test treatment threshold and there is a test discharge threshold. And we would like our index test to be useful to us when we are in the zone of uncertainty. So before doing the test, the probability of the disease, or in other words, the pre-test probability is generally in this zone, the zone of uncertainty. It is because there is uncertainty that we want to do the test. But after doing the test, we want the probability of the disease, or in other words, the post-test probability, to be in one of these zones. That means either in the zone of treatment or in the zone of discharge. So a test that does not take you from the zone of uncertainty to either the zone of treatment or the zone of discharge is a useless test. That means it is still leaving you in a zone of uncertainty. So you want a good test to leapfrog you from the zone of uncertainty to a zone of treatment or to zone of discharge so that you can take action. So how do you decide on the test treatment threshold? I'll just give you two common examples, but for each disease, it will be different. So on the left side, if you take a disease which is rare, whose progression is slow, where immediate fatality is less, where the therapy has a lot of adverse effects, where the treatment duration is long, treatment cost is high, and the consequences of over-treating patients is very bad, then you are likely to have a high test treatment threshold. Typical example is cancer chemotherapy, where you can't afford to go wrong when you're treating the patient. On the other hand, if the disease is common, if progression is rapid, if immediate fatality is high, if the therapy has less adverse effects, if treatment duration is short, if treatment cost is low, and the consequences of overtreating are not so bad, then one would tend to have a low test treatment threshold. A typical example is neonatal sepsis. So effectively, you are gambling between risk and benefit. So for example, if for a particular disease, you have mentally kept a test treatment threshold of around 80%, which means you're telling yourself that, well, if the probability of the disease is around 80%, I'm going to go ahead and start treatment. Then what are you effectively doing? you're effectively thinking that the consequences of over-treating up to 20% subjects is acceptable, since 80% or more are actually benefiting from the treatment. On the other hand, if you set your test discharge threshold as 10%, which means you're telling yourself that, well, if the chances of the disease are less than 10%, I'm not going to take any further action. No more tests, nothing. I'm just going to observe the patient. Effectively, what you're doing is you think that the consequences of under-treating up to 10% subjects is acceptable, since 90% or more are benefiting from no treatment. So there are basically two types of tests, and these reflect the two types of variables that we usually deal with. The first are tests with binary results. So it is in the very nature of the test that it is either positive or negative. For example, ultrasonography for detecting intraventricular hemorrhage in neonates. So either there is hemorrhage or there's no hemorrhage. And there can't be anything in between. Blood culture for sepsis, either it's positive or it's sterile. Cytopathology, either there is cancer or there's no cancer. On the other hand, there are other kinds of tests which have continuous results, but a cutoff defines what we call positive and what we call negative. The cutoff is man-made and could change over time. And sometimes there may be no consensus on the cutoff. So different researchers may actually end up using slightly different cutoffs. And these kind of tests are very common in clinical practice. Typical example is C-reactive protein, CRP. It's basically comes as a continuous result, but conventionally, more than 10 milligrams per liter is considered to be positive, and anything less than 10 milligrams per liter is considered to be negative. So let's start off with tests which have binary results. Let's start with interestingly, not all. And amongst those who are not septic, a certain proportion has actually turned out to be CRP positive, the bottom left. Now, these are the test CRP negatives. Again, amongst those who are non-septic, the vast majority CRP negative, but not all. And amongst those who are septic, there are some who were not supposed to be CRP negative, but they happen to be CRP negative. So therefore, this group is called the test true positives. That means they have sepsis and the test is indeed truly positive. This group is called the test true negatives. They have no sepsis and the test is indeed truly negative. This group are the test false negatives. That means one would have expected the CRP to be positive, but they have turned out to be falsely negative. And these are the test false positives. That means the CRP had no business to be positive amongst these non-septic individuals, but a certain number, it has turned out to be falsely positive. So what is sensitivity? Sensitivity is test true positives divided by all those who are diseased. That means it answers the question, amongst those who are truly diseased, in what proportion is the test truly positive? So in our example, the denominator was 40, as you already know, and the numerator were 8 columns and 4 rows, 32. So that was 80% or 0.8. So sensitivity in our example is 80%. It is also known as the true positive rate of the test. And in simple English, sensitivity answers the question, proportion of diseased patients have a positive test? What proportion of diseased patients have positive sensitivity? So 1 minus sensitivity is just the mirror image of that. So in the numerator, it has the false negatives. The denominator is the same, the diseased individuals, which in this case, as you can see, is 80 by 40 or 20% or 0.2. And that is exactly the opposite of sensitivity. So sensitivity was 0.8 or 80%. 1 minus sensitivity is 20%. This is known as the false negative rate of the test. Now let's go on specificity. In specificity, the numerator is the test true negatives and the denominator are the non-diseased. So basically, amongst the non-diseased, what proportion are those who do not have sepsis, what proportion are CRP negative? That is specificity. So in this case, it is 42 by 60, or in other words, 70% or 0.7. It's also known as the true negative rate of the test. So specificity in simple English answers the question, what proportion of non-diseased patients have a negative test? That means, in our example, what proportion of non-septic patients will have a negative CRP? That is specificity. What proportion of non-septic patients would have a negative CRP is specificity. So 1 minus specificity is the other way around. So on the numerator, you have the false positives divided by the non-diseased, which in our example is 18 by 60 or 30% or 0.3, which as you can see is 1 minus specificity is 0.3. This may also be called the false positive rate of the test. Now let's switch gears and try to understand what is positive predictive value. Positive predictive value, the denominator is different. The denominator is all those who are test positive. So it is amongst those who are all CRP positive, what proportion are true positives? That means what proportion actually have sepsis, blood culture positive sepsis, amongst those who are CRP positive. So if you can just work out the rows and columns, you would find that the denominator is 50, the numerator is 32, which is 64%. And I would like you to remember this figure, 64%, because it's going to come later again, or 0.64. So this is also known as the post-test probability. And in simple English, positive predictive value answers the question, what proportion of patients with a positive test are diseased? That means the denominator is all those who have a positive test, all those who are CRP positive. Note that it is different from sensitivity. In sensitivity, the denominator was all those who are diseased. In positive predictive value, the denominator is all those who have a positive test. Amongst them, what proportion are truly diseased? Negative predictive value, it is true negatives divided by all test negatives. So amongst those who are test negative, that means amongst those who are say CRP negative, what proportion are truly negative? So in our example, that is 42 by 50, which is 84% or 0.84. Again, please try to remember this figure 84% because it's going to come in another exercise that we're going to do in a short while. So the negative predictive value, simple English, is what proportion of patients with a negative test are not diseased? That means amongst those who come to you with a negative test, what proportion are not diseased? That means amongst those who come to you with a negative CRP, what proportion of them actually do not have sepsis? So it's very similar to the process when you're buying an apple. Imagine that you go to the market, you want to buy apples. For an apple, the gold standard is what is inside the apple, the flavor, the sweetness, the crunchiness, and so on. But you don't have access to the gold standard when you are buying the apple. What you have access to is the diagnostic test, which is the outside of the apple. For example, the color, the shininess, the fact that it's not soft in parts, it is nice and firm. So all this is part of your diagnostic tests. Now, at the time of taking the decision of which apple you should buy, Which of these questions will provide the more useful answer? The first question is, of all apples with a good flavor, how many have a red skin? The second question is, of all apples with a red skin, how many turn out to have a good flavor? And I would leave you to ponder about this for 5 seconds, and then I'll tell you which question will provide the more useful answer. Well, it happens to be the second question. Of all apples with a red skin, how many have a good flavor? Because the first question assumes that you already know the gold standard status of the apple. If you already know, then knowing whether it interest only. But what is more useful at the time of buying is, of all apples with a red skin, because that is the only thing that you have available to you, you want to know amongst them how many will turn out to have a good flavor. So the first question is actually sensitivity, because good flavor is in the denominator of all apples with a good flavor. The gold standard is in the denominator. How many have a red skin? So that is sensitivity. The second is positive predictive value. That means of all apples who come with a positive index test, diagnostic test, what proportion actually have a good flavor? That is positive predictive value. About diagnostic tests is sensitivity, specificity are useful to the clinician who's trying to arrive at a diagnosis, but that's actually wrong. The reality is that sensitivity and specificity assume that the gold standard status of the patient is known. But it is predictive values which give an idea of the post-test probability of the disease, which are actually more useful to the clinician. The sensitivity and specificity is useful to the statistician from a statistical point of view, but predictive values are actually more useful to the clinician. Now let's move to another population, a population which 60% of patients with suspected sepsis have a positive blood culture. That means they're truly diseased. Remember, in the previous population, only 40% with suspected sepsis had a positive blood culture. So here, the prevalence, the pretest probability becomes 60% or 0.6, and no sepsis is 40% or 0.4. Sensitivity and specificity are expected to be similar across populations who have the same presentation. So now let us calculate what the positive and negative predictive values would be, assuming that sensitivity and specificity is the same. So what happens to the positive predictive value? When the prevalence of the disease changes, the denominator changes. Denominator and numerator actually change. Now the hatched circles are 60. These are the total number who are CRP positive. And amongst them, there is a certain proportion which is gold standard positive, which is in the numerator, true positives. So it's 48 by 60, which is 80%. Now just remember, the previous example that we did, the positive predictive value was only 64%. It has now risen to 80%. So what do we conclude from that? We conclude that as the prevalence of the disease increases, the positive predictive value also increases. So the positive predictive value is not constant. It depends upon the prevalence of the disease in that population, assuming that the sensitivity and specificity remain the same across populations. What happens to negative predictive value? In the new example, in the new population, the denominator, those who are CRP negative are only 40, and those who are true positives in the numerator are 28, which makes it 70%. Remember, in the previous population, the negative predictive value was as high as 84% when the prevalence was only 40%. But with the prevalence increasing to 60%, the negative predictive value has dropped to 70%. So the moral of the story is that as the prevalence of the disease increases, the negative predictive value decreases. So the second big myth about diagnostic tests is that, we have said that positive and negative predictive value are great things for a clinician. But the problem is this myth. If you think that you can get the PPV and NPV of a test derived from another setting and start using it in your own setting, you are sadly mistaken, because the prevalence of the disease is different in different settings. So positive predictive value and negative predictive value change depending on disease prevalence. As the prevalence increases, the positive predictive value increases and negative predictive value decreases. As prevalence decreases, the positive predictive value decreases and negative predictive value increases. So just a few light-hearted examples. For example, if Saurabh's MANTU test is positive, he is more likely to have tuberculosis than if Barack Obama's MANTU test is positive. And why is that so? The MANTU test is being done in exactly the same way, interpreted in exactly the same way. And yet, in one country, if you are MANTU positive, you are more likely to have tuberculosis than in another country. And the reason is simple. The prevalence of tuberculosis is much higher in India compared to the United States. If Donald Trump's sweat chloride is positive, he is more likely to have cystic fibrosis than if Narendra Modi's sweat chloride is positive. Why? Because cystic fibrosis prevalence is much more common in Caucasian populations than in India. So the result of the test has to be interpreted in the background of the prevalence of the disease in that population. The CRP for sepsis has a much higher negative predictive value in the community than in the PGI NICU, because for the same constellation of signs and symptoms, patients presenting exactly the same way, there's a much higher chance that it could be sepsis in a tertiary care NICU than in the community. So what is the way out of this dilemma? If I'm saying that sensitivity and specificity per se don't help the clinician in arriving at a diagnosis, it is predictive values. But predictive values, on the other hand, are highly dependent on prevalence. Then how do you go about it? So likelihood ratios are a way out of the dilemma. Now, likelihood ratios are a little complex, so it's important to understand this carefully. So the likelihood ratio of a positive test is the probability of the test being positive amongst the diseased divided by the probability of the amongst the non-diseased. So the numerator, many of you would instantly recognize, is nothing but sensitivity. Means what are the chances of the test being positive amongst those who are diseased? That means amongst those who are gold standard positive. The denominator is a 1 minus specificity or the false positive rate. That means what is the probability of the test being positive amongst those who are non-diseased? So that is sensitivity upon 1 minus specificity, which in other words is the true positive rate divided by the false positive rate. The likelihood ratio of a negative test is the probability of the test being negative amongst the disease in the numerator divided by the probability of the test being negative amongst the non-disease. So the denominator, test being negative amongst the non-disease, is nothing else but specificity. And the numerator is 1 minus sensitivity, or in other words, the false negative rate. So the likelihood ratio of a negative test is the false negative rate divided by the true negative rate of the test. Putting it graphically, if the numerator brown circle is all those who are diseased, and the denominator green circle is all those who are non-diseased, and the yellow circle is a subset with the test result. So if the test result is positive, then we're looking at a positive test result amongst the diseased divided by a positive test result among the non-diseased. If the test result is negative, that means negative likelihood ratio, that means it is a negative test result amongst the non-diseased numerator divided by a negative test result amongst the non-diseased in the denominator. Why do we even bother about likelihood ratios? We bother about likelihood ratios because of an interesting mathematical property that it has, and that the pre-test probability can be converted via the likelihood ratio to a post-test probability. I'm not going to go into the maths of this, but it's a simple, it can easily be derived. There's no great mathematics involved in it. So what were the likelihood ratios in our study? Remember, The sensitivity was 80% and specificity was 70%. So the likelihood ratio for positive test is sensitivity upon 1 minus specificity, which is 0.8 by 0.3, which is 2.66. Whereas the likelihood ratio of a negative test is 1 minus sensitivity on specificity, which is 0.2 by 0.7, which works out to be 0.28. Now we are going to use these two values. To make it simple for clinicians, a statistician by the name of Fagan published the Fagan's nomogram in the New England Journal of Medicine way back. Now, what does this nomogram consist of? It consists of 3 vertical lines. The left-sided vertical line is the pre-test probability expressed as a decimal. So it extends from 0.01 on the top to 0.999 at the bottom, which basically means the pre-test probability of the disease before you've even done the test, extending a range of probabilities extending from 0.1% to 99.9%. On the extreme right is the post-test probability of the disease, extending from 0.1% to 99.9%, except that it's the graph is flipped. So it's 99.9% on the top. And in the middle, you have a vertical line saying likelihood ratio, extending from a maximum of 1000 down to 0.001. Most likelihood ratios that you would normally deal with in real life would extend from a maximum of around 15 to 20 down to around 0.07 to 0.1. Now let's take examples. Positive CRP in our population, the likelihood ratio of a positive test was 2.66. So our patient, remember, had a 40% pre-test probability of the disease. If you join 2.66 on the likelihood ratio line with 0.4, the pre-test probability line, and with a ruler, you extend the line to see whether it cuts the post-test probability, that turns out to be 68%. So effectively, what are we saying? When the patient came to us with non-specific signs and symptoms, there was a 40% chance that this patient had true sepsis. We did a CRP, the CRP test came positive. Now that the CRP test has come positive, the probability of it being sepsis has risen to 68% from 40%. So the post-test probability is now 68%. Let's take another individual with a lower pre-test probability of having the disease, say 10%. So now my line will cut 10%, it will cut 2.66, and then if you extend the line, it cuts the post-test probability line at 22%. So what does this mean? It means that if someone comes with only a 10% probability of having sepsis, I do a CRP, the CRP is reported positive, then this individual has only a 22% chance of having sepsis. It's not a 100% chance. It's only 22% chance. Let me take an individual with a higher probability of having sepsis. Say somebody who is really sick looking, and this is a 70% probability of having sepsis. Maybe it's a tertiary care setup where a lot of sick, vulnerable patients are there. The CRP comes positive in this patient. This patient has an 88% chance of having sepsis if the CRP is positive. So what does this tell us? That the test cannot be interpreted in isolation. You have to know your patient. What was the patient's pre-test probability of having the disease? If the chances of having the disease were already high to begin with, then the way the test is being interpreted is different, because the post-test probability is then very high. If the chances of having disease were low to even begin with, then a positive test does not change the probability very much. So suppose I say that my zone of treatment is anybody with a 50% chance of disease and above, for sepsis. It means that the blue patient and the red patient, if they have a positive CRP test, I'll be willing to treat them. But the green patient, I will not be willing to treat, because even after doing the CRP, it is still for me in the zone of uncertainty, 22%. I would like to do one more test of some other kind to be able to settle the issue. So going back to this old diagram. So the patient comes to you with a zone of uncertainty, and a test must have a positive likelihood ratio that enables you to make this jump if the test turns out to be positive, that means into the zone of treatment, and should be able to make this jump if the test turns out to be negative. If you can't make the jump, you need to do other tests serially till you exit the zone of uncertainty. Now, what about tests with continuous outcomes? An ideal situation would be, so here are test results which are following, for the sake of simplicity, a bell-shaped curve. So a whole range of. So the ideal situation would be where test results amongst the diseased are clearly separated out from the test results amongst its close differentials. But the real life situation is that the range of test results that you get amongst those who are truly diseased often overlaps partly with the range of results that you may get amongst those who form the close differentials of that disease. So for a continuous variable, one could have several cutoffs. So how does one decide what is the optimal cutoff? Now the thing is that sensitivity and specificity change as per cutoff. Let's take an example. We're again going to talk about CRP and blood culture. So bottom now you find CRP values in milligrams per liter. It is not to scale. So starting from 0 and then going upwards to the right towards 100 and beyond. And we are going to take a population of patients in which 100 patients, of which 50 are culture positive and 50 are culture negative. The culture positives are being shown as red circles as before, culture negatives as green circles. So suppose this is my population and I've lined them up like this. They are 5 rows and 20 columns to make it 100 patients. Now, suppose I have the choice of CRP cutoffs at 5 milligrams per liter, 10 milligrams per liter, 25 and 50 milligrams per liter. Let's see what happens at each stage. If I take 5 milligrams per liter as my cutoff value, then note that anyone above 5 milligrams per liter, I'm now taking a CRP positive, less than 5 milligrams per liter as CRP negative. So let's see what happens to sensitivity. Sensitivity is amongst those who are gold standard positive. That means amongst those who are culture positive, in this case, amongst the red circles, what proportion are CRP positive? So CRP positive amongst the red circles, almost all are CRP positive, except for those 2 red circles which are on the left side of the vertical dashed line at 5. So 48 out of 50 becomes my sensitivity. For specificity, what proportion of culture negatives are CRP negatives? So amongst the greens, how many green circles are to the left of the 5 dashed line? You'll find that a very small proportion. Most of the greens actually on the right side. So this is what it is. The sensitivity at 5 is 48 by 50, which is 96%, but the specificity is very low. It's only 18 green circles to left of 5, 18 by 50, so it is 36. When I take 10 as the cutoff, then the sensitivity drops. So I have only 41 red circles to the right of 10, so 41 by 50, so that's 82%, whereas the specificity has now risen to 54%. If I go further to 25, the sensitivity has dropped further to 62%, specificity is increased to 80%, 82%, and I've calculated it all out for you. So at 50, the sensitivity is a dismal 34%, whereas the specificity has risen to a very impressive 94%. So what is our conclusion? The conclusion is that there is an inverse relationship between sensitivity and specificity. As you increase the cutoff value, your sensitivity drops and your specificity increases and your specificity drops. So how do you express these index tests that have continuous variables? you express this in the form of an ROC curve. What is an ROC curve? An ROC curve is a plot of sensitivity on the vertical axis and 1 minus specificity on the horizontal axis. So instead of 1 minus specificity, you can write it as specificity, but you can flip the axis by 180 degrees so that you have 0%, the red 0% on the right side and 100% on the left side. If it was 1 minus specificity, then 0 would have been on the left side and 100% on the right side. Now for each of these cutoffs, 5, 10, 25, 50, I plot those dots depending on what was the sensitivity and specificity for that cutoff. And when I do that, I'm able to join up these dots and create a ROC curve. So each cutoff yields its own sensitivity and specificity. The area under the ROC curve, which is the overall performance of the test, is a proportion of the area under the curve as a proportion of the total area of the square. So the square is equal to 1 because it is 1 multiplied by 1. And the proportion under the ROC curve is called the area under the ROC curve. The greater the area under the ROC curve, the better is the discriminatory value of this test. Remember that this shaded triangle, which is below the diagonal line, has an area of 0.5. So this is the area that coin tossing would have. So you want your area of the ROC curve to be above this coin tossing line, above 0.5. And the closer the area is to the value of 1, away from 0.5, the better is the test which expresses a continuous variable. Now I've finished an hour of talking. So I'm going to conclude by saying that test results are not interpreted in isolation, but with the background knowledge of pretest probability. This is the age-old teaching that professors in medicine have always been telling, that don't treat the test result, treat the patient. You have to know your patient. Because depending on what was probability of having the disease the patient had even before you did the test, your test result will get interpreted differently. Sensitivity and specificity describe the test. They do not help in decision making. It is predictive values that help in decision making. Positive and negative predictive values help enable diagnosis when a test result is available, but they are influenced by prevalence. And lastly, likelihood ratios allow the post-test probability to be calculated, and they can be used across populations, as I showed you. You can derive it from the sensitivity and specificity, and for your population, find out what is the post-test probability when you're using it on a given patient. Thank you very much. I would be happy to take any questions.
Thank you, sir, for such a nice informative presentation. The session is now open for questions. Anybody can ask questions.
Sir?
Yes?
Hi, this is Chetan, sir, pediatric pulmonology, sir.
Yeah.
Sir, hello?
Hello, yeah, go ahead.
Yes, sir. Sir, can the likelihood ratio be directly multiplied with pretest probability, or is it supposed to be pretest? Hello?
No, it can't directly be multiplied. It actually goes through pre-test odds and it generates post-test odds. So the pre-test probability, yeah. So to avoid all that mathematical jugglery,
yes, sir.
Fagan decided to make the nomogram,
Okay.
making it appear as though you're directly converting pre-test probability into post-test probability, but actually it is going through pre-test odds.
Okay, sir.
To post-test odds, and that is being back converted into probability. It can easily be done.
Yes,
it's just that it's,
But in the normogram, we are supposed to use probability on both.
Probability, yes. At the normogram, you are supposed to use probability.
Okay. Thank you, sir.
Thank you. Yeah, any more questions?
So Dr. Meenakshi is asking that can we make ROC curve for binary test?
No, you do not make ROC curves for binary tests. However, you could use an ROC curve where it is a polynomial test. That means, it's it is categorical, but it's ordered categorical variables. That means there are 3 or more options available which are in a particular order. So from that means you have 3 points available from which you can make an ROC curve. But it's not very informative because you have so few points from which you are making the curve. It's typically used in tests which have a continuous distribution.
Okay. Anyone have any question?
Inform everybody that just like how you use the consort guidelines for assessing the the publishability of a randomized control trial, you use STARD guidelines for diagnostic tests. They are available on the Equator website. So if you just type in Equator and put in standard guidelines for reporting studies, it'll give you all the various guidelines. STARD is for diagnostic tests, and some of the key issues in the STARD guidelines are that the population selected for in the study to begin with. So you should not have any healthy controls, nor should you have some extremely diseased controls in which the diagnosis is obvious. Because in real life, you will be using the diagnostic test in amongst those who have diagnostic uncertainty. That's where you want the test to work the best. You are never going to use it to distinguish those who have obvious disease from those who are healthy. That's not the purpose of a good test. A good test should be applied on those who have diagnostic uncertainty and should be able to tease out the truly diseased from the differentials. That's an important point. Any more questions?
There is another question. How to interpret the area under ROC, for example, a 0.485. How to interpret area under ROC, for example, 0.485.
Okay. I'll get to that figure of 0.485 a little later because there is a catch in it. But let us assume that the area under the ROC curve is more than 0.5. Say suppose it is 0.7. So ROC curve helps us in many ways. For example, if there are 2 or 3 tests that you want to compare head to head, and all of them give results in the form of a continuous variable. Say you want to compare CRP versus procalcitonin versus interleukin 6 diagnosis of sepsis, and all of them values are in as a continuous variable. So CRP could be anything from 0.5 milligrams per liter to 200 milligrams per liter. Procalcitonin could be anything in nanograms per ml. Similarly with IL-6. Now the trouble is, how do you now compare them head to head? It's not so simple, because depending on where I put a cutoff to make it binary, I would get different sensitivities and specificities for each of these 3. So I can start picking and choosing my cutoffs to get a better sensitivity for one test versus the other at the cost of specificity and vice versa. So it becomes very difficult to do head-to-head comparisons of 2 or more tests, all of which are in the form of continuous variables. So ROC comes to our rescue. The test with the bigger area under the ROC curve is the better test, because overall, irrespective of the cutoffs, it is better capable of discriminating between those who have the disease versus those who don't have the disease. That's point number one. Point number two, in general, the test which has an ROC curve closer to the value of 1, that means you're getting closer to the 0.9, 0.95 and so on, that is a good test. It's able to discriminate. Thirdly, for for a sort of a real life way of understanding area under the ROC curve, supposing you have pairs of patients, one of whom is truly diseased, one of whom is not diseased, and you randomly keep picking up pairs of patients, then the area under the ROC curve, say supposing it was 0.6, or in other words 60%, area under the ROC curve tells you that in 60% of these pairs you would have correctly classified the diseased patient and the non-diseased patient based on this test. You would have correctly classified 60%. If the area under the ROC curve was 0.9, or in other words 90%, it means that if you had, say, 100 pairs of subjects, 100 diseased and 100 non-diseased, and you were to randomly start picking out pairs of patients from this, one diseased, one non-diseased, then in 90% cases, your test would correctly have classified the diseased person and the non-diseased person. In 10%, it would have wrongly classified, but in 90%, it would have correctly classified.
Thank you, sir.
Sir, I have another question.
Yeah, go ahead.
Yeah. So for a single test, if we look at the ROC curve, does it also help us to choose a particular cutoff that will give us the best sensitivity and specificity for that particular situation?
Yes. Yeah. You can derive the best cutoff, which gives the best trade-off between sensitivity and specificity. So there are various ways of doing this. One of the ways is that if you have a nice smooth curve, then you can draw a reverse diagonal line. That means from the top left coming down to the bottom right.
Yes.
The point at which that diagonal line cuts that curve, the cutoff value of the index test at that point where it's cutting, that is taken as the optimal threshold or the cutoff mark. One way. The other way is you can use something called Uden's index. So Uden index is sensitivity, both being expressed in decimals. So if sensitivity is 0.9, specificity is 0.8, then it becomes 0.9 plus means 1.7 minus 1. So that is 0.7.
Yes.
So you calculate the Uden's index for every possible cutoff. I mean, every point on the ROC curve.
Yes.
And then you see which one gives the best Uden's index. That is the point at which you get your best trade-off between sensitivity and specificity. That is the threshold. Okay?
Okay. Okay, sir. Thank you.
Yeah.
Are there any more questions?
No, ma'am. I think there is no more question.
How to can we make ROC curve for binary tests? How to interpret area under ROC, for example? I think all these have been taken up.
Yes, ma'am.
And Dr. Sourabh, I must compliment you for making all these difficult concepts seem so easy. And we all have learned from what you have told. I mean, we always like to listen to your talk. And if there are no more questions, we can take the feedback. Or is there anything we need to discuss? There were small areas, you know, where time periods when we were losing contact. So I think that must have been because of the network problems.
Yeah.
I don't know whether they were similar everywhere else, but for me also I got a little problem. So must compliment Dr. Sourabh, and thank you very much.
Thank you. Thanks a lot.
So I've shared the feedback form with everyone. Kindly request you all to stay back for 2 minutes and share the feedback with us. Thank you.
If the feedback has been completed, then we would like to close the session. Is that right, Praveen?
Yes, ma'am.
Is there anything left?
No. 20 seconds is left for the feedback form.
Okay. Praveen, as your this thing is hanging today, the background of the echo, please take a picture of that and
Yes.
you know, make a slide out there.
But our side it is okay, ma'am. There is no much problem of connectivity.
All right. Okay.
It's once or twice only.
Yeah.
Okay, the feedback is over now. So we can bind the session. Thank you, sir. Thank you, everybody, for participation.
And thank you, Praveen, for conducting the session so well. Thank you.
Thank you, ma'am.
We'll all meet next week again.
Yes.
You can now close the meeting.